Thank you for coming to this special group of talks and presentations relating to women's health and wellness, specifically focusing on breast health, breast care, and keeping women as healthy as possible. Today, I have the honor of introducing you to a very amazing lady. Her name is Dr. Laura Pomerenke, and she is a breast care doctor surgeon with UC Health here in Colorado Springs. And she has been working and helping women all over Colorado, and she just has a passion for helping women and their health. So without too much more ado, I'm going to go ahead and let Dr. Pomerenke speak. Thank you again for coming.
My pleasure. So thank you for showing up today. I know these are challenging times. COVID seems to be not going away like we had hoped, but I appreciate everyone being here. And I am always happy to talk about something that I'm very passionate about, and that is breast cancer. As you know, breast cancer is the most common cancer in women after skin cancer. But it is not the most common killer of women. That would be lung cancer. So we see many, many women with breast cancer. The vast majority do great. And that's one thing that I really want to emphasize. When you see, 1 in 8 women get breast cancer, only 1 in 32 women will die of it. So early detection, finding these cancers when they're easy to treat, when you don't have to do bad things to people, and you are more likely to be cured, is really the key. And that, of course, comes down to screening. So we are trying now to really emphasize tailored treatment. We don't want to treat you like you, like you, like you. We want to identify patients who are at maybe high risk for getting cancer, as well as identify people who are at low risk for getting cancer. Because we know that, all of our screening tests, they're great for finding cancer, but unfortunately, nothing's perfect. And sometimes they pick up normal things, and then you have to go through biopsies. And, all that creates a lot of stress and anxiety. So we really want to emphasize screening for the patients who are at high risk and maybe back off screening at the patients at lower risk. If you're 70 years old, maybe you don't need to have a mammogram every year. If you have a strong family history of breast cancer, or maybe you carry a mutation, maybe you need to start your mammograms when you're 30. So identifying risk factors, looking at lifetime risk, we can really do a much better job of screening and finding those cancers as early as possible. So risk factors include things like age. The biggest risk factor for getting breast cancer is getting older. Most cancers happen in older people. And the reason is that every time a cell divides, the DNA has to be duplicated exactly. And it's not. So we make mistakes. And we have little spell checkers that come along. They're supposed to identify those mistakes before they get passed on to the next generation of cells. Some people's spell checkers are better than others. And so you do hear of families where like everybody has had some type of cancer. We don't have the fine tools to identify what's wrong with those people, but certainly they are probably at higher risk. So if your spell checker doesn't work right and the damage gets passed to the next generation and the next generation, you can develop cancer. One of the things that we spend a lot of time talking to our patients about is family history. We know that that is probably one of the strongest risk factors to developing breast cancer in the future. So we do what's called a 2-generation pedigree. So we look at the first generation, which is your mother, and then the second generation, which is grandparents. But we also include cousins and nieces and nephews because we want the biggest picture we can to see what the risk for cancer is. And we don't just ask about breast cancer. We ask about colon cancer, pancreatic cancer, ovarian cancer. So there are multiple cancer syndromes now that we can identify and test for. It always amazes me when I have a family that, my aunt had it, my grandma has it, my cousin has it, and you think, okay, this has got to be somebody with a mutation, and we test them and they're normal. So clearly, our knowledge of genetics is about that big right now, which is better than it was 20 years ago. But this is the beginning of really understanding what's going on in our DNA and being able to tailor and individualize screening for those people. So we talk about family history. We look at ages of diagnosis. Somebody diagnosed at 30 certainly has a higher risk of a mutation than somebody diagnosed at 70. So we always want to know how old were they when they were diagnosed? What kind of cancer was it? We hear a lot of, well, maybe it was ovarian, but it could have been cervical, but it could have been uterine. So those are totally separate cancers. And the risk associated with each of those is very different. Ovarian cancer is not very common. And if it's seen in a younger woman, has a very high incidence of having a mutation. Uterine cancer, typically we see in older women. It's typically not genetic, although there is a syndrome where you can see a higher risk. And cervical cancer, we know, is more related to the papillomavirus and is not genetic. So once we do a second generation pedigree, we can look to see if somebody qualifies for genetic testing. Genetic testing used to be really expensive. There was one company in the world that did it, and it was about $5,000. And insurance were pretty rigid about who they would qualify for testing. It was a lot of money to ask somebody to pay out of pocket. Subsequently, they lost their patent, and we now have multiple companies that do genetic testing. So currently, the out-of-pocket cost is about $250. But in most situations, insurances will pay for it. So we now have large panels of genes that we look at. 20 years ago, we looked at BRCA1 and BRCA2. That's all we had. And if you were negative for those two, there was a whole slew of other things, but we didn't know about them. Now we have a panel that tests more than 84 genes. Some of them we don't even know what they do. So when we send off genetic testing, we want to make sure that patients understand what the results mean. So if you are negative, well, that's great. It certainly does not mean that there isn't something going on in your family, though, if you have a family history. We just don't have a test for it. You can be positive for a mutation. There's 9 specifically that are associated with breast cancer. The BRCAs probably have the highest risk, and that's 80% in your lifetime. Most of those are in younger women. So we start to see the cancer rate go up at about 25 to 30. Those patients need extra screening, and we even talk to them about preventative surgery. They are also associated with ovarian cancer. So there's about a 40% risk of getting ovarian cancer with one of those mutations. And ovarian cancer is really bad. It's hard to find early. By the time you do find it, it's usually spread. The treatment is not as successful. So it is a really bad cancer. So ideally, we want to get those ovaries out when someone's done having kids. And that can significantly reduce the risk of getting ovarian cancer in the future. There's other mutations that increase the risk some, between 40 and 80%. So we talk to our patients about what that means. And sometimes they will elect to go ahead and have preventative surgery. Other patients will just want to be screened, and usually we'll do mammograms and MRIs every year. Again, we want to find those cancers as early as possible when they're easier to treat and more successfully treated. There are some mutations that increase the risk a little bit, maybe 20 to 30%. So that comes down to more of an individualized discussion with patients. We would still recommend screening with MRIs and mammograms, but maybe preventative surgery is not as much of a benefit anymore. So everybody's just different about how much risk they're willing to tolerate. For some women, it is really stressful, and they just elect to have surgery and be done with it and not have to worry about getting breast cancer. For other women, that's too aggressive, and they're comfortable going ahead with screening. So a lot of what we do is what we call shared decision making. We want to talk to patients about what their options are. We want to give them recommendations, but ultimately, it's the patient's autonomy to make those decisions for themselves. So once we've done our genetic counseling, we can go off and send testing. That's usually either a blood test or a little cut if you spit into a bunch, that goes to a lab, and then it's about 2 weeks or so to get those results back. If we have someone who has been diagnosed with breast cancer, and they have a family history, we want to get those results back because it can certainly affect what kind of surgery they want to have. If they are found to have a significant mutation, they may wish to be more aggressive surgically and not have to worry about getting a second breast cancer in their lifetime. If all their genetics comes back negative, then they may feel much more comfortable doing a lumpectomy and then just our routine follow-up. So I think those genetic testing results are really, really important in order to make an informed decision. The average woman who gets breast cancer who does not have a mutation really has a very small risk of getting a second cancer. It's between probably 5 and 10%. And that's less than a normal woman. A normal woman has about a 12% risk. Some of the treatments we use for breast cancer, the anti-estrogen medicine, helps to reduce that risk as well. So we know that we can prevent about 50% of new breast cancers from forming by doing the anti-estrogen blockers. So genetic testing has come a long, long way, and it really does guide us in making recommendations for screening as well as for treatment. Other risk factors we look at include kind of gynecologic history. When did your period start? When did you go through menopause? How many kids did you have? And how old were you when the first one was born? So those have all been found to be small risk factors for getting breast cancer. We look at them as kind of a global picture. We would never say, oh, well, you had your first kid at 35, your risk of getting breast cancer is 50%. So we have all these calculation tools that we use. There's different risk models. They range, sometimes it's just silly. So you put all the information in and it comes back that you have a 20 to 40% risk of getting breast cancer. Well, I could have told them that, So unfortunately, we don't have anything that's very precise. And even the best of our risk models are only about 70% accurate. So it gives you more of a kind of gestalt of what their risk is and not really a specific number. Some of the risk models look more at family history. Some of them look more at abnormal biopsies. So when we see someone who's come in and they've had a biopsy, they've got some little funny cells, we know that that can increase their risk in the future. Again, probably not a huge amount, but some of these things do add up. So if you have a funny biopsy and family history, that might be enough to warrant doing some additional screening. If you've just had a funny biopsy and your history is completely normal, then you probably don't need that. So the family history, abnormal biopsies, all kind of go into that calculation device. We look now at breast density. So on the mammogram report, you will get a letter that says, you have very dense breast tissue. And so that's a law that Colorado passed along with many, many other states, because we know that women who have dense breasts, their mammograms are not as sensitive. Breast cancer is white on the mammogram. Breast tissue is white on a mammogram. So if you have really dense breasts and there's not a lot of fat in there, you can hide a little cancer. So it's like looking for a snowman in a blizzard. You know, he can be right in front of your face and you just don't see him because of all the snow. We have some mini tools now where we can negate the effect of breast density some. So there's something called tomosynthesis, or the 3D mammogram. Instead of smashing everything into 2 views, they take little slices of tissue now, and that is shown to be significantly better, particularly in women with dense breasts. You can really see things much more clearly if you don't have to look through the whole breast and you're only looking at a thin slice. They have what's called whole breast ultrasound, which almost looks like a scanner. And so it scans the whole breast with an ultrasound machine. We don't use it a lot now. Probably one of the indications is someone who has very dense breast tissue and are at higher risk, but maybe not enough risk for an MRI. Any of these tests will pick up more cancers, but they will also pick up normal things. So we call those false positives, and they are not good. I mean, it means more imaging, more biopsies, more anxiety. So we always want to balance the benefit of finding more cancers versus the harm of finding normal things that have to be followed or looked at more. Because it is really stressful. I mean, I'm sure everyone in this room understands when you get that call back, it rocks your world. And, you know, until they get that sorted out, you are kind of living on pins and needles. So we have to balance those things when we make recommendations for more screening. MRI is the most sensitive way we have of looking at the breast tissue, but it also picks up many false positives. So it's not uncommon at all that women have to come back and do more ultrasounds and sometimes even MRI-guided biopsies because we just don't have a better way to figure out if something is cancer or not. So once we have done our full analysis, we come up with a number. If that number is over 20% lifetime risk, so that's going to be different depending on your age. If you are looking at a 30-year-old, they have most of their lifetime ahead of them. If you're looking at a 70-year-old, you know, they may have 10, 15 years left. So the amount of risk they have is reflected in how old they are as well. An older woman is going to have less risk because she's only going to live 15 more years. A younger woman is going to have more risk because she's got maybe 55 years ahead of her. So we have to kind of balance that as well. So once we get the final estimate of what their lifetime risk of getting breast cancer is, we make recommendations for screening. For some women, it's just going to be a yearly mammogram. For other women, it's going to be adding MRI and again, possibly ultrasound. For our highest risk women, we start MRIs at 25 and we start screening mammograms at 30. Yeah, I know, and that's a lot of imaging to go through. And it takes a lot of fortitude for these ladies to say, okay, I'll do that for the next 50 years, you know, and it's almost like, you know, there's this time bomb ticking over your head. When am I going to get it? So I think that's where the genetic testing is really helpful. If you're come back negative and you do not have one of these mutations, it probably does lower your risk. The problem is when you have a strong family history and those people have died, we can't test them. So we don't know if they had a mutation and you didn't get it, which means you are normal, or maybe there isn't a mutation in the family and it's one of the things that we don't know yet. So genetic testing helps, but sometimes it doesn't give us like the full picture, and we still have to go based on family history. For women who are at elevated risk, and again, we usually use about 20%. If they're motivated, we can also do what's called prevention. And so multiple studies have been done looking at women who have a 5-year risk of about 1.7%. And they found that by giving them a small dose of anti-estrogen, they were able to reduce the risk of getting breast cancer by about half. So if you have somebody who's got a 30% risk and they take tamoxifen for 3 years, they can reduce that risk to 15%. And that benefit continues beyond when they stop the medicine. So we've known this now, we've had prevention studies since the 90s. The problem is it's been kind of hard to sell this to women. You know, they come back and they've had a funny biopsy and we kind of say, okay, we think your risk is 40%, but they don't have cancer. And then we say, well, do you want to take this pill that can give you hot flashes and night sweats, maybe blood clots, maybe uterine cancer, or we can give you this other pill that can cause osteoporosis and maybe joint aches and make your hair fall out. So it's kind of a challenge to get people to say, yeah, sure, that sounds great. So the Italians came out with a study a couple years ago. The standard dose of tamoxifen, which is an estrogen receptor blocker, we use that to treat breast cancer with, and it's been around since the 50s. So the standard dose is 20 milligrams a day for 5 years. And that's just because that's what we do. You know, all of the studies have used that dose. They've all used that time period. Now we're actually extending that in younger women with cancer. But again, that's where you're going to see the hot flashes and the night sweats and possible blood clots and uterine cancer and everything. So the Italians did a nice study where they only went and used 5 milligrams a day, so just a quarter of the dose, and they did it for 3 years. And they found no increased risk of hot flashes and night sweats. They found no increased risk for uterine cancer and no increased risk for blood clots. They still saw a 50% reduction in the risk of getting breast cancer. So by blocking those breast cells from dividing, from growing, and those damaged cells turning into cancer, they were able to just kind of put the lid on it. And so we now have 15-year data on the original tamoxifen studies, and those women who took it continue to get breast cancer at a lower rate compared to the women who took the placebos. So for some of our women who are at higher risk, who want to be a little bit more aggressive with prevention, this has been a really nice thing to offer them. And like I said, very few women have stopped taking because of side effects. In some women, you know, once they finish their course after 3 years, we're able to stop doing the MRIs or stop doing the ultrasounds because now their risk is actually back in the normal range. So we have some ways of helping to reduce the risk that we know are very effective. We look at lifestyle. So some of our risk calculators include things like, you know, breast density, how much do you weigh, smoking history. So all of those things, again, affect your risk, but kind of little bits. So smoking, finally, they figured out increases the risk, but they had to do a bunch of studies to see it. So it's a little bit, you know, instead of 1, it's like 1.1. Being overweight, particularly after menopause. You know, women think, oh, I've gone through menopause, I don't have any estrogen left. So that is not true. Your adrenal glands make steroids, and then your fat tissue has an enzyme in it called aromatase. And that aromatase enzyme converts the steroids into estrogen. So women who gain weight or are overweight after menopause have a higher risk of getting breast cancer. So we think, at least, that once these cells get damaged, the breast tissue has receptors for estrogen and progesterone. This is what turns those cells on. And so that's why when you're having your periods every month or when you're pregnant, your breast tissue changes. And it changes because of those hormones. So the more cycles you have, the more risk there is of some damage progressing into cancer. By blocking those hormone receptors, we can again turn those cells off so they don't progress into cancer. The cycle theory kind of is one of the reasons we look at how old were you when your period started. If you were young, if you were 10 versus 15, well, that's 5 more years of your breast tissue doing this. How old were you when you had your first child? If you were 35 or 40, that means you had a lot of hormones going on when your tissue was maybe already a little damaged. So that again is a little bit of a risk factor. We see a little increased risk in the first 5 years after pregnancy. So you always hear that pregnancy is protective, breastfeeding is protective for breast cancer, but in that first 5 years after a pregnancy, you see a little increased risk of getting breast cancer. And again, it has to do with all the hormones that are necessary, for having a baby and feeding it. So those are some of the things that we look at as well. We look at the use of hormone replacement after menopause. So we know from the Women's Health Study that came out in 2002, and they basically followed a bunch of nurses, like 10,000 nurses over many years, and they were looking at lifestyle factors, diet, alcohol use, smoking, exercise, what kind of diet? Are you eating a lot of animal proteins? Are you eating more plant-based? So this is one of the biggest lifestyle factor studies that's been done. And they came out with the results that going on hormone replacement therapy, combinations, so estrogen and progesterone, increased the risk of getting breast cancer by about 50%. You had to be on it for 4 or 5 years. The risk decreases after you stop taking it, but it never goes back down to where it would have been otherwise. And it's only the combination hormone replacement that does that. Women who took estrogen only did not see an increased risk. And potentially it was actually a little bit less. So progesterone causes the proliferation of the breast cells, the growth, and that's where the DNA damage can progress into cancer. So one of the things we talk to our patients about if they're on hormone replacement is why are they on it? Sometimes back when I first started in 95, I would say 60–70% of our patients were on hormone replacement. And they were basically told, you're going to be on this the rest of your life. This is going to keep you young. It's going to keep you from getting Alzheimer's. It's going to keep your heart good. So we kind of know that that's probably not the case now. There are some new ongoing studies looking at starting hormone replacement younger versus when you're older to see if that might be protective heart-wise, but they really haven't panned out that well. So when we see someone who's on hormone replacement, we always ask them to say, okay, well, how long do you think you need to be on this? Some women will have hot flashes the rest of their lives. And I've had 80-year-olds who are still doing this. And it's not fun. I mean, it won't kill you, but it's not fun. And there are certainly women who really cannot stop their hormones. I mean, they are just miserable. We talk to them about alternatives. Acupuncture has been shown to be very effective at managing menopause symptoms. And not just hot flashes, not just night sweats, but it helps with sleep. It helps with the sense of kind of wellness. So acupuncture is something that doesn't have any side effects. I wish insurances covered it routinely, but it is somewhat variable. Some of the antidepressants that inhibit the uptake of serotonin will be helpful. Serotonin is kind of your feel-good hormone. So things like Prozac and Effexor and Lexapro are called serotonin uptake inhibitors. And they can help reduce the number of hot flashes and night sweats. They help with sleeping sometimes. Sometimes they have side effects. And I think using them short term to get through menopause is a great idea. But I'm always, whenever you put somebody on a pill, you should always ask yourself, how long do I need to take this? Because, as you get older, things just keep getting added on. And sometimes nobody kind of looks at the list and says, why are you still taking that? So I think as a patient, it's always a good idea to have that conversation every year with your doctor. So the SSRIs are a decent way of managing it. Things like Neurontin, which is actually a seizure medicine. But again, these all kind of have some side effects, whereas the acupuncture does not. They've shown that meditation is good at managing menopause symptoms. Again, you're releasing serotonin, you're releasing dopamine, and it really helps. Even doing 10 minutes, in the morning will be enough to really help some people. And then exercise. Again, releasing those good hormones, really effective way of managing menopause. They've looked at the effects of diet, and I wish that there was like something really obvious that we could tell patients, don't eat bacon, but no. And unfortunately, I have like the skinniest little vegan patients come in with breast cancer. So again, it's a small risk. We recommend patients limit the use of animal fats. Red meat, full fat dairy products, all of that has a lot of fat in it. And unfortunately, those animals are probably getting some hormones to make them get big and strong faster so they can kill them sooner. So you're eating those hormones. Again, there is no evidence that organic or natural reduces the risk of cancer. These things are so small, and what we did when we were 20 probably affects our breast cancer risk when we're 60. Well, we don't follow people that long. We don't start those studies that early. So we recommend a plant-based diet, limiting the amount of animal fat you're eating, particularly things like red meat, and doing more skim dairy products, low-fat things, to kind of minimize the amount of animal fats that you're eating. And then also minimize your own fats. And again, the estrogen production from that. Alcohol has been a little bit controversial. Again, these self-reported studies are not always the best. How much do you drink? One drink a day, and it's one bottle instead. So people tend to underreport some things. Alcohol is metabolized in the liver, and it can increase the risk or the development of estrogen. So if you see, an alcoholic man, they probably have breasts because they have a higher estrogen level. So the recommendation to limit alcohol use for women, they say 1 drink a day. Probably if you really want to reduce your risk, you're going to want to do less than that. And, again, is it that much risk or that much risk? It's just kind of hard to know. Otherwise, we don't have any special supplements that help to reduce the risk for breast cancer. There was some interest in vitamin D in the past. I think more studies have really shown there's probably not a benefit to taking vitamin D supplement unless you're really deficient. And so some physicians still check vitamin D levels routinely. I think it's probably better to get checked in the summertime than the wintertime because, your vitamin D levels probably fluctuate. And again, exercise, maintaining, a healthy body weight. We start to see a higher risk. We use BMI of 35. And in our patients with breast cancer, we are now a lot more, forceful at making recommendations to meet with our dietitian. We know that women who have a BMI over 35 have a higher risk of recurrence by about 50%. So it is a significant part of their survivorship to try to lose weight and maintain a better body weight, because we never want breast cancer to come back. Once we make these recommendations, we like to have our high-risk patients follow up in a special clinic that we run. So they're seen typically twice a year by our nurse practitioners. We make sure they have a good breast exam. Unfortunately, breast exam stuff has been I think, very confusing for patients. We always used to say every month, do your breast exam. And then they kind of did some more studies and showed that most patients didn't, first of all. Most patients didn't know what they were looking for. The little breast models we used to play with at the health fairs, they had little marbles in there. Breast cancer doesn't feel like that. And so a woman would feel a fullness and be like, well, it didn't feel like the model, so it's nothing. And it turns out that's how some cancers feel. So now we recommend that women know what their breast feels like. It doesn't have to be anything fancy. You don't have to stand in the shower and, do circles or whatever radial, but just know what your breast exam is like. And then if it's different, that's something you should tell your doctor about. If you feel something and it wasn't there last month, that's a reason to be concerned. It's a little different for premenopausal women because their breast tissue changes. They still have a lot of hormones going on. They're going to have a lot more fluctuation in their breast tissue. When you get in your 40s, you start getting cysts and everything. So we don't ask patients to figure out if something is a cyst or not. If it's a difference, then tell your provider. They'll probably want to refer you for a mammogram and maybe an ultrasound, and then see one of us if there's a problem. But I think getting to know what your normal is very important. I still see a lot of women who find their own breast cancers, and they've had a mammogram or they've been doing their studies regularly, and they feel a lump. So it's really important still to know what's going on, particularly if you're higher risk. So getting in that habit, because it is a habit, and it's something that you get better at. Women are always like, well, I don't know what I'm feeling. It's like, well, the more you do this, the better you're going to get, and the more confident you will be. So when they come in and say, that was not there last month, then I know that was not there last month, and it's something that we need to look at. If they say, I don't know, then that's kind of hard, and we're still going to work it up. But you certainly have a lot of information that you can just get from a physical exam. Any questions?
Yeah, so if you have a question, if you want to give us the question, then Dr. Pomerenke could maybe restate the question, and then she could talk about it. Okay.
There's been a little controversy about women with a history of breast cancer, how we should screen them. And what we've kind of decided, so in our program, we just do mammograms once a year. We're going back to just doing screenings. And the benefit of that is it's the same views that you get from a diagnostic, but you don't have to pay for it. So a diagnostic mammogram is $500. Screening mammograms should be covered under your insurance. It's the same exam, it's the same radiologist looking at it, and we feel that the risk of having a recurrence is so small that there's really no benefit to doing additional imaging. For young women who've been diagnosed, there's been a little controversy about should they also do MRIs. When they've looked at the data more, the women who have mutations or who are at elevated risk because of family history, there is probably some benefit to doing MRI in addition to mammograms, at least until the breast tissue becomes less dense. For women whose only risk is that they had breast cancer, there was no benefit to doing additional screening with MRI. You in the front, yes.
I have some questions. So, one of them has to do with the mammary mice virus or mice mammary virus, however you want to say it. When I was reading things because of all the stuff I went through last year, I found it so interesting, and I don't know, can you talk about that a little bit?
Yeah, so we are fortunate because we're affiliated with the university, and they are doing a lot of research. They do clinical trials with new drugs, but they also do some basic research looking at the very beginning of cancer. And so they have developed particular viruses that will affect mice, and they get breast cancer a lot, which is great because then they have all these cancers that they can look at. They can look at different mutations. They can look at different pathways that the cancer is growing through. And there's the potential for vaccines. And so these are early trials. There's a protein called HER2 that about 20% of breast cancers have. They tend to be very aggressive cancers. And in the old days, they were bad. They were bad, bad, bad. And then in the late 90s, they found an antibody that was developed in the mouse model that has completely changed the management of these cancers. So they're not really, so Herceptin is widely available, and now we have several other HER2 blockers. Again, they're all targeted therapies, which is really our goal for cancer. You know, we want to be able to target the cancer cell, but not the immune system, not the hair, not the mouth, you know, all the other side effects that come along with chemotherapy. You know, if we can just target the cancer cell, then you don't get sick. You don't end up, you know, having to go through all the yucky chemo stuff. So they've actually looked at a vaccine for HER2 positive cancers. So another way to keep these cancers from coming back again. And they're looking at vaccines for the mammary virus. So it's still early. Hopefully, you know, in 20 years, we will be able to identify people that are at increased risk and give them a vaccine. You know, probably in 20 years, cervical cancer will be very rare because now we have a vaccine for the virus. So, I mean, that's the exciting thing is being able to prevent cancer and not just have to treat it. And I think that's one of the reasons that we do a lot of genetic testing now, because if you wait until somebody has cancer and you test them, you know, you've just missed that opportunity to prevent them from getting cancer. So we always, if we find a mutation, we recommend that they talk to their family, they get their kids tested. You know, you want to know those things before you get it and not after.
So I have a question for you. So with the BRCA gene, like for instance, I got tested, I was negative. I have two daughters, and would it be appropriate for them to be tested as well, or because?
Yeah, so that's the beauty of being able to test the person who's had cancer, because they are the one who's at risk for having the mutation. You get a good gene and a bad gene. So you get a gene from your mom, a gene from your dad. So you can get the BRCA mutation or any of the other ones from your dad's side. And it can be kind of tricky to see it because men don't usually get breast cancer. So, you know, maybe his mom had it or his aunt, and maybe he carries the gene, but the chances of a man getting breast cancer, even if they have the gene, is small. It's like 3%. But he could give it to his daughters. So if we can, we want to test the person who has cancer because they will be the biggest yield. The fact that you don't have it means you did not give it to anybody.
Okay.
So they're good.
Yes.
Now, again, there's still that, you know, we do 84 genes. Probably 10 years from now, we'll do 800 genes. So they should know their family history. And we always encourage patients, you know, I think Thanksgiving is supposed to be the day that you talk about cancers in your family. I don't know. But, you know, keeping an eye on those things. And if you hear, oh, yeah, your cousin just had it, and or, you know, your niece just had it, kind of keep track on that stuff because, you know, that does add up. And those people, you know, when they come back and say, geez, I just found out that my niece had it and she's 30, you know, now all of a sudden our ears are going to kind of prick up and we're going to go, you know, did she have testing done? And so testing is just widely available now. And really anybody I diagnosed under the age of 50 should have genetic testing because, again, that's the group that we're more likely to see it in. There are people who feel that anybody with breast cancer should have genetic testing because there is still, you know, even if you're 60 or 70, there's still a risk you have a mutation. And then the family members need to be tested, or at least be made aware. So yeah, your daughters, they are good to go.
I have another question. So I do have dense breast tissue.
Well, because you're young and skinny.
Well, that's nice of you to say. But yeah, so when does breast tissue become less dense? Because I did not feel
Mhm.
a little tumor.
Which is good.
Had no idea. The tomography.
Right.
So it saved my life. Yeah.
So typically, we look at breast density as a combination of things. It depends on age. You know, younger women who have higher hormone levels are going to have dense breasts. So if you put up a 40-year-old's mammogram and a 70-year-old's mammogram, they look totally different. So if you do a mammogram on a 30-year-old, you are not going to see very much because it is all white. That tissue is just very dense. What normally happens after menopause, your hormone levels go down. The estrogen and progesterone receptors are not being stimulated. So the breast cells will basically atrophy and turn into fat. And so if you look at a mammogram in somebody when they're 40, they're 50, they're 60, they're 70, you can see this evolution where the breast tissue just basically shrinks. There's more fat, which is much easier to look at. And by the time you're 70, your breasts are just fat, basically. Now, you can still get cancer, of course, but they're just fat. So that's the good news and the bad news. So what happens when you go on an estrogen blocker, which is about 70% of breast cancers are driven by estrogen and progesterone, you go on that blocker, basically it's putting those breast cells into a dormancy. So they atrophy. And usually, even after just 1 or 2 years of being on a hormone blocker, you can see on the mammogram that it's much less dense, it's much more sensitive exam, and that tells us that it's working.
Interesting.
Now, if you have somebody who's heavier, they're going to have more fat in their breasts, and their tissue's not going to look as dense because your breast is made of breast tissue and fat. And it's that ratio that affects the breast density. Any other questions? All right, well, get your mammograms. Get your mammograms so you find these things early when you don't have to go through bad stuff. Yeah.
Thank you.
And they've actually shown survival benefit to getting mammograms in their 40s. And women who get diagnosed on a mammogram are much less likely to need chemo. All right.
Thank you. Well, thank you so much.
Very much. And if you are worried about your risk, have your doctor send you over, and they'll be more than happy to run the numbers and see what it looks like. All right, my pleasure.
Thank you.
Hope everyone stays healthy, COVID-free.
Okay, so we're going to take a small break right now, and if people want to, we have a little bit of vegetables, plant-based.
Plant-based diet, yes.
Yes. And we'd love for you to join us.